I'm excited, and I think for community oncologists, it's important to know that now we have another weapon. You know, when you're working in the trenches and seeing large number of patients with lung cancer, some of them will have more traditional actionable mutations like EGFR and ALK, and others of them will have PD-L1 positive now, and they'll be getting immunotherapies right off the bat, or certainly they'll get immunotherapy later on. But for those that have this V600E, now we know we have a combination, trametinib, dabrafenib, that has activity. I think one would expect response rates anywhere in the 30 to 50% range. How durable, that's still, you know, the test of time will tell. And they'll need to look for some GI and skin toxicities, but it's not much different than what we're used to dealing with some of the other TKIs that we work with. So I think that it's hope, and you know, my goal for my patients and my hope in precision medicine and lung cancer is that someday everyone will get fully profiled and we'll have a series of agents, and then we'll match that agent to the drug, and that's targeted therapy. And you know, this is just one more piece of the puzzle. Of course, now we have to figure out how to target KRAS, which is 20 to 25% of the patients, for which we really don't have a combo. Some of it might include the drugs we're talking about here, either being used with immunotherapy or with PI3 kinase inhibitors, but right now, this is a step in the right direction. I'd expect that if the patient responds, symptoms oftentimes will improve, because I think the response will supersede whatever added toxicity you get to the drug. So I'd say they should expect response 30–40% of the time with some improvement in symptoms, but again, the data are still limited. Well, oftentimes in lung cancer, if you're going to use a combination such as trametinib and dabrafenib, you would want to have data preclinically in lung cancer or strong data in another tumor type. And of course, we know in melanoma, that combination against V600E, which is more common in melanoma, is actually more efficacious and less toxic than using the trametinib by itself. You know, the trametinib, of course, being the MEK inhibitor. So it's very exciting, and I think that extrapolation to lung cancer, it still needs larger trials and randomized studies, but I think there's certainly a sense that this combination can be active in lung cancer as well.
The metastatic melanoma experience, both from a BRAF point of view as well as a immunotherapy point of view, actually, now that we kind of have that in common with melanoma, I think there are a lot of lessons or a lot of themes that run consistent between the two diseases. You know, the combination first demonstrated in malignant melanoma patients being more effective than single agent therapy. I think we don't have that level of evidence in a randomized fashion yet, but you know, as I said previously, I'm not sure that it's, given what we've seen in this between cohort A and cohort B, that I would be enthusiastic about doing a randomized trial where in other disease settings like melanoma, we've seen a clear advantage to the combination. And at least in this sequential cohort trial of cohorts A and B, we've seen a clear difference or in signal with the combination versus monotherapy. So I don't think we should reinvent the wheel there. I think we should proceed with a dual inhibition as our platform to move forward.